My name is Lourdes. I am a patient advocate with the Cholangiocarcinoma Foundation, and we are happy that you're here joining us today for today's webinar. Just as a reminder, our speaker cannot answer specific patient questions, so please try to keep your questions as general as possible. I think it looks like most people have logged on. So I want to introduce our speaker. Paige Griffith is a senior nurse practitioner in the gastrointestinal oncology program at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. She earned her bachelor's degree in genetics from Clemson University in 2010 prior to receiving her bachelor's degree in nursing from the Johns Hopkins University School of Nursing in 2012. She worked on the solid tumor oncology unit at Johns Hopkins prior to graduating with her master's degree as an adult gero acute care nurse practitioner from the Johns Hopkins University School of Nursing in 2018. She is also an oncology certified nurse. Paige specializes primarily in the treatment and management of patients with primary liver cancers, including hepatocellular carcinoma and cholangiocarcinoma. And she serves on the Nursing Advisory Board of the Cholangiocarcinoma Foundation, in addition to the Advanced Practice Provider Council at Johns Hopkins Hospital. Thank you, Paige, for being here with us today.
Thank you, Lourdes, and thanks everyone for joining. This is a topic that I manage and deal with on a regular basis and understand why patients have a lot of questions and challenges, both with the diagnosis and the complications of the diagnosis of cholangiocarcinoma, specifically in regards to biliary stents and drains and the management of those. So just, I'm going to try to break it down to make it as understandable as possible, but again, welcome questions along the way. I can be interrupted, which is just fine, or we can do questions at the end. Why are we dealing with biliary stents and drains in regards to cholangiocarcinoma? How do we deal with them? And then what do we do once we have them? And so the big question of why, I think when patients are diagnosed with cholangiocarcinoma, you walk into an office and people are referring to different bile ducts and different anatomy, but I think without pictures and sometimes scans, it can be very difficult to understand what the implications of what is being said means in regards to why stents are needed and so on. Usually you're just, if you're diagnosed because you're having jaundice or you're having abdominal pain, and the next thing you know, you have a procedure, you don't even have time to digest what is happening. And so there's three subtypes of cholangiocarcinoma. Let me just get that one. First is extrahepatic cholangiocarcinoma, and this is broken into two categories. So there's hilar, or also known as Klatskin tumors, and then there's distal extrahepatic cholangiocarcinomas. And I will, this picture on the left, I think, shows it a little bit better. You can see extrahepatic, meaning outside of the liver. Hilar is at the main bifurcation of the two ducts, so where the tree separates. And then intrahepatic cholangiocarcinoma. So these are ones that are within the liver beyond that main bifurcation. The CT scan on the right, I tried to put it side by side with the cartoon of the liver, but what the arrow is pointing at is ductal dilation, and we'll talk about what that means. But when somebody comes in, whether it's a new diagnosis or when patients are already on chemotherapy, and someone says, "Oh, you have ductal dilation and you have to get a stent placed," this is what we're seeing on the scan. And the way I describe it to patients is it's like someone has stepped on a garden hose and the other side of the hose is getting very large and engorged because there's nowhere for the flow of the bile to go. And so there's not supposed to be dark areas in the liver like we're seeing on the right, but that is what ductal dilation looks like. And so why does this happen? This is a cartoon of what the tumors can look like. There's different types. There's extraluminal compression, and this is tumors on the outside of the small bile ducts that can be pushing on it. There's also intraluminal compression. So this is when the tumor, the cancer cells are growing from the inside of the bile duct lumen and growing out. And so, as you can see in the top left, each of these can cause the same type of problem. And one can imagine that in order to open that lumen, which is the green area or the bile duct, you need to put some sort of stent in there to open it. The middle row of pictures shows stones, not necessarily relevant in this setting, but this is another reason people get stents placed. The bottom right is a good picture of an extrahepatic cholangiocarcinoma, a distal extrahepatic cholangiocarcinoma. So it's beyond that big bulb is the bile duct, is the gallbladder, and it connects into the common bile duct. So if you have an extrahepatic distal cholangiocarcinoma, this bottom right picture shows where the compression is on the outside of the liver. And so why does all of this matter? We're talking about bile ducts and bilirubin, and what does it mean, and what is the impact? So bilirubin, pretty simply, is a byproduct of hemoglobin breakdown. So hemoglobin are the red blood cells in your body. They are involved in oxygen transportation, and so there's many cells, and so these get broken down on a regular cycle. There's a small picture on the right of what the cycle is. The bilirubin, once it's broken down, enters the liver, and then it can be excreted into the small intestine, the large intestine, the kidneys, and some circulates back to the liver. So what happens if bilirubin levels are high in patients? This clinically leads to jaundice, which is the accumulation of bilirubin in the blood, in the skin or the eyes. And so this is when patients appear yellow or a little bit brown-like. Often it's most apparent in the eyes. The whites of the eyes turn yellow. Patients also can have pale colored stools, dark urine, it's almost coke colored, skin itching, or pruritus is the other name for that. Can have diarrhea, but that can be from many things, not just elevated bilirubin levels. So more importantly, what are the risks of having a high bilirubin? One could say, okay, my bilirubin is high, do I have to do something about it, or is this something we can monitor? And the level of which we intervene is different in different folks. So sometimes people will see a bilirubin of 10, 15, 20, but it can just be 2 or 3. And so, at some points we monitor, but the risks of having a high bilirubin, cholestasis, which is that the bile is blocked and not moving. One of the big risks is that it favors bacterial growth and proliferation. So it can cause infection in the bile ducts, also known as cholangitis. It's probably a word that many people have seen in their charts and in the documents when they've been reading things about themselves, which obviously infection can be local to the liver, but it also bacteria can get into the bloodstream, and it can cause sepsis, which obviously is a much more challenging and difficult situation to treat. Often requires hospitalization. Another risk of having a high bilirubin, the biliary dilation, which we talked about in that first picture, that backup and the backflow in the liver can cause liver damage if that pressure is not relieved. So having all the extra pressure build up within the liver doesn't allow it to function as it normally should. It has many processes, which we can't get into today because it's involved with many different cycles and processes of function throughout the body. And so that kind of leads into the second one, that the cholestasis affects the liver blood flow. In order to get toxins out of the body, which is one of the primary functions, you have a large supply of blood that comes into the liver, is filtered through the liver, and then leaves after being filtered. And if all of this is backing up because there's bile backed up, this can cause significant liver dysfunction. And then lastly, normal substances that are excreted by the liver backflow into the systemic circulation. So if you build up toxins, it can cause confusion, and it can cause just downstream effects or upstream effects, however you want to see it. It can cause issues with kidney function and so on. All of the other organs often rely on the liver to be able to do their processes. So if it's not functioning because of this bile backup, other functions can't work. So this is why it's important that we actually address elevated bilirubin levels with things like biliary stents. So the next step after we know that somebody has an elevated or we think somebody has an elevated bilirubin, we have to actually diagnose it. So how do we know if there's a bile duct blockage? Often people who treat patients with cholangiocarcinoma are aware of common signs such as jaundice, like we talked about, abdominal pain, itching. A set of labs is often very helpful. What we're looking at specifically in those labs is the bilirubin level, the liver function tests. So these are the alkaline phosphatase, the AST, the ALT. Not always, but you will sometimes at least see the alkaline phosphatase elevated. And sometimes you'll see the alk phos elevated and not the bilirubin, as that often will go first. But either way, the last thing we're looking at, it's not specific, but patients with cholangiocarcinoma often have an elevated CA19-9, which is a tumor marker number. We can see that that a CA19-9 can be elevated in the setting of obstruction. So especially in patients that are newly diagnosed, the CA19-9 can be extremely elevated if there's a significant bile duct blockage. And once that blockage is relieved, we'll see that CA19-9 come down, and then we can use it more realistically as a tumor marker to gauge treatment response. So after a physical exam, providers get a set of labs. The next step is often an ultrasound. I put a picture at the bottom of what dilated ducts look like on an ultrasound. I think it's interesting. People tell you what the results show, but this is what they actually look like. In many cases, if the diagnosis of cholangiocarcinoma is known, providers will often jump to a CT of the abdomen or abdomen and pelvis as the first step, because it can be a little bit more specific about the blockage, and you can see where it is or which side of the liver has dilated ducts. And then lastly, and it's not necessary, but we see more and more of them, it's called an MRCP. It's a special type of MRI that looks at the bile ducts. And so I think there's a pretty neat picture on the right of what a hilar tumor looks like on MRCP. So the arrow points at it nicely, but you can see the biliary tree that comes up. You can't see the outside liver, but one could imagine what that looks like. And you can see the area that there's a black spot and that the ducts aren't continuous. And that's how one could see where a tumor would be sitting and causing compression on that bile duct. So we need these images, labs, etc., to be able to determine the next steps. And so the next steps are is the how. And so there's a few options, two main options that we use. The first one is an endoscopic retrograde cholangiopancreatography, or ERCP, is much easier to say. This is performed by gastroenterologists in the hospital. It can be an outpatient procedure, but sometimes patients are already inpatient and get this while they're in the hospital. Either way, so the doctors use an endoscope with a catheter that goes down through the throat. There's hopefully you guys can see it. There's a picture on the bottom left there. So the camera goes in, and the camera has this little side piece with a guide wire that injects contrast in the bile ducts. You can do an ERCP to get brushings, they're called, or to get biopsies. This is one way, and one of the most common ways that cholangiocarcinoma is biopsied initially, but it's the same method that we use to be able to go into the bile ducts to put a stent in. And the stents can be both plastic or metal. Plastic stents are smaller. So if people have if the bile duct is very tight and restricted, you often have to start with a smaller French stent. And over time, you'll have to go for multiple repeat procedures, and they can increase the size of the stent to allow for better flow of the bile. Plastic stents are typically more temporary and prone to occlusion or blockage, whether it's from sludge or from tumor compression, but they're often where the endoscopists start, and then metal and more permanent stents can be placed later down the road. Another and very common way that these are also done is through a percutaneous transhepatic biliary dilation with drain. And so I know a lot of the questions are, what's the difference between a stent and a drain? Often a stent is internal always, but sometimes they have to be connected to an external drain, and we'll go through some of why. And so the percutaneous drains are placed by an interventional radiologist. So also typically an outpatient procedure where you go into the interventional radiology suite. They use CT machines in real time, and they shoot dye in so they can see where the blockage is. And they go in from the outside of the liver to be able to access the bile ducts. So the problem being is if we try ERCP first, if they are not able to pass through a constricted bile duct, we have to access it from the outside. And this happens quite commonly. Or if you do have an internal stent placed initially, but you're continuing to have problems, we often have to go in with an external drain to try to bypass it on the other side and drain some of the bile on the outside into a bag. So let's see, this results in an external drainage system that requires flushing, which I think many people are familiar with, and that's where a lot of the questions lie. Occasionally a drainage bag. So in most cases, and I think I talk about this a little bit later, patients are actually connected to a drainage bag for about 24 hours after the external drain is placed, just to allow for that initial decompression. You have all that backflow into the liver. So if you leave it connected to a bag, a lot of that will decompress, decrease some of the stress on the liver. But at the same time, as you can see in this middle picture, also actually all three pictures show it, the drain is trying to has a guide wire that bypasses all the way. That squiggly line is the duodenum, or the small bowel, that's labeled in the middle picture there. And sometimes the internal stent is not enough, or it cannot pass all the way through. So you have a small drain that can get all the way through to drain on the inside and the outside. On the far left and the far right, you'll see two different pictures. Many people have more than one external biliary drain, and people ask, why do I need more than one? Or they start with one, and sometimes we have to add a second, sometimes even a third. And it's because there's multiple branches to the biliary tree, and depending on the size of the tumor or location of multiple tumors, you have to address the drainage from multiple sides. They often start with one. If the bilirubin isn't coming down successfully, they'll often have to approach from the other side. These must be exchanged. These drains must be exchanged at regular intervals to prevent occlusion and, more importantly, infection. I think this shows a good picture of once a stent is sufficiently in place that it is holding the tumor apart. And this is an internal stent, so this is not one that drains on the outside. So that's an ERCP, an endoscopy scope that has come down and inserted a stent into that area. Now, when we're monitoring, or when I'm managing patients who have internal stents, the education I provide, importantly, is to monitor for signs and symptoms of further obstruction. So this goes back to the very beginning, the jaundice again, dark urine, pale stools, abdominal pain. If this happens, patients often require upsizing of the stents or replacement. So the tumors are capable of growing into the stents, and that's what can cause further occlusion, or sometimes the stent is only so long, and so sometimes tumor on one end of the stent can end up blocking it if the stent is not long enough or needs to be positioned differently. And also sometimes it's sludge or just really thick bile that can build up in that stent. Also important is monitoring for signs and symptoms of infection. So this could be shakes, or rigors is the medical term for when people have pretty violent shaking, just mild chills, fevers, abdominal pain. And I think what's important is discussing with your GI interventionist what the frequency at which they suggest changing the stents. In most cases, it's somewhere between 8 and 12 weeks, or sooner if patients are having the above mentioned problems. In terms of an external drain, the management in some aspects is similar, that you are monitoring for the same things. For the same reasons with the internal stents, re-obstruction is unfortunately common and occurs multiple times for various reasons. And so we talked about the signs and symptoms of obstruction before. Same thing, but also I think slightly more important with external drains is monitoring for signs and symptoms of infection. But in terms of external drains, this can be both at the actual skin site, or this could be a bloodstream infection. Again, discussing with interventional radiology or IR, the frequency at which they suggest exchanging the stents and drains, it's a pretty similar timeline, about 8 to 12 weeks, unless there are problems sooner. Now, it gets much more complicated with external drains, and I think as many of you are familiar with, they require a lot more maintenance, and patients are often requesting, can I have an internal drain placed? Why do I keep having to have this on the outside? But unfortunately, without being able to flush and keep the bile moving through with the drain in place, the obstructions will continue to happen. So generally, these drains need to be flushed with 10 cc's twice a day. If prone to clogging, which many of them are, they might need more frequent flushing. So sometimes people need to do it 3 times a day, 4 times a day. If you have resistance when you're flushing, or you cannot flush, this is what I mean by it's clogged. The dressing needs to be changed on the outside at least 3 to 4 times weekly, or more if they are leaking. These drains, these external drains leak pretty regularly, unfortunately, and sometimes there's so much pressure when they're newly placed that bile, the pressure that's built up in the liver has forcing bile around the drain that needs to be upsized, is often what IR will do to help if they are leaking. So a little bit of drainage at the site is not uncommon. If you're going through 1 to 2 dressings a day, they will often leave it be. But if you're saturating a dressing every hour, that is not normal. As I discussed earlier, a drainage bag is typically attached for 24 to 48 hours for initial decompression and then capped. Cholecystostomy tubes, which we didn't really get into, but these are tubes that go into the gallbladder, are permanently open to drainage. So if you have a cholecystostomy tube, these would never be capped. So on the left is a very jaundiced abdomen, but there's an external drain, and what you can see, there are stitches at the site. Those are very important to monitor at the site, because sometimes there's an infection just at the skin site. So pus can come out, stitches can get dislodged. These are things that you'll be looking for. The middle is what the external drainage bag system looks like to some degree. It's a little bit different at every institution, but it's going to be something with a cap on the end. You'll be measuring your output, draining the bile into the toilet typically, but keeping a close eye on that. And then on the right is what a capped biliary drain looks like. So there's still a mechanism that you have to flush multiple times a day, but there's not the whole drainage bag attached. Further on with the external drain management, some patients require frequent antibiotic regimens, either IV or oral, for recurrent infections. I think I may go back to a previous picture. I have this conversation very frequently, and actually I think this is a good picture. So where the endoscope is entering this common bile duct, there's a sphincter at that site that is a normal anatomical place that keeps from backflow of gut flora, which is not sterile, into the biliary tract. But unfortunately, when patients have an endoscopy that needs for stent placement, for example, a sphincterotomy or a cutting of that sphincter has to be done. And what that puts patients at persistent risk for is the non-sterile gut flora can go back up retrograde into the common bile duct and into the remaining liver. And so once that sphincterotomy has been done, it can be very difficult, especially if a stent is holding open the lower part of the bile duct. It can be very difficult to keep bacteria out of the bile duct tract. And so this is one of the reasons that patients sometimes have to be on home antibiotics, have to be hospitalized for IV antibiotics, or need constant oral antibiotic regimens. You are able to go to work, you're able to work out, you're able to exercise, but we recommend avoiding frequent bending and rotation, twisting, if you will. Drains may need to be left open to drainage if one cannot tolerate capping. So people who have recurrent cholangitis or recurrent infections of the bile tract, sometimes interventional radiology recommends leaving the biliary tubes, the biliary bags open to drainage instead of capping them. Also, some people cannot tolerate them being capped, and their liver function tests get elevated. Sometimes the bilirubin increases again, and the only way for the bile to escape is through the bag because none of the bile is able to bypass into the small bowel, and that does happen. It is okay to travel via airplane. I do recommend and provide documentation of the device on just a letter for TSA screening, although it's not required. I think it helps. Usually there's clips holding bags on, or you have a bag holding all of the external drainage bags together, a variety of things. So I think if you can get a letter documenting this, I think it makes it easier for TSA. But we do like our patients to travel and to get out and enjoy life as best as possible when they're dealing with these challenges. It's okay to shower daily, but to not submerge in a tub or pool. This is an open area of skin on the outside if there's an external drain, and bacteria, that's another source for bacteria to be able to get into the body. And it's one less thing that we need when you're trying to manage these. So be sure to secure the tube and or bag. On the right, I have an example of something called an aqua guard. They can be a bit expensive, but they can be found online. This is something that's sticky on all four sides, and you can cover the drain area. I'm a big fan of saran wrap press and seal. It works kind of the same way to cover these drain sites as you're showering, and then you can change the dressings after the shower. So I've tried to stress these throughout the conversation, but reasons to call in relation to biliary drains or stents, or honestly just having cholangiocarcinoma in general, even if you do not have stents or drains present, are infection signs and symptoms that we went over, leaking at the site, any frank blood in the drainage bag. So sometimes there's clots, there's small areas of blood, but if everything that is coming out is blood, then you need to call either triage or get into the ER quickly. There can be bleeding events from the liver, although not common, from getting these placed. Worsening abdominal pain, usually if there's a blockage or something going on, it's an acute worsening abdominal pain, meaning within hours it was significantly worse. This isn't typically something, if it's a problem with the drains or the stent, it's not something that slowly changes over 1 to 2 months. I mean, it's usually a few hours or a few days time. Odor or pus at the insertion site, like I talked about, there can be a skin infection from, but that's why just changing the dressing and keeping that site clean is important as best as possible. Acute onset of no drainage. So if you are somebody who needs to be connected to a bag continuously and suddenly the drainage is not coming out at all, and you used to have a decent amount, that would be a reason that you need to call. Often they'll try to tell you to flush it, to try to maneuver anything that may be clogging it. But it's an important reason to call. Again, back to flushing. If you cannot flush your tube, if you have a drain that's capped, and you're trying to push in the saline and it's either leaking around the tube or not going at all, you'll need to call into interventional radiology to get their recommendations. Sometimes they have to exchange the tube if it is clogged. Another tidbit for patients who are persistently connected to a drainage bag and you have high output, meaning you're putting out like more than 1 liter of bile a day. This can be quite dangerous because you lose electrolytes and some other fluids in that bag, and you can get dehydrated very easily. So sometimes they'll tell you to cap it for a few hours, or they may need to do other interventions to be able to make sure you stay ahead on your electrolytes and your fluids and so on. A simple, but one that can happen easily, because the bags or the drains on the outside are very easy to get snagged on clothing and things like that. So if the stitches become dislodged or the tube moves or falls out, that is certainly another reason to call. So that is what I have. And I would love to answer any questions that folks may have, and I can go back and reference slides, whatever you need.
Thank you, Paige.
Yeah.
If anyone has questions, please, you can enter them in the Q&A or the chat. While we're waiting for questions to come in, I want to just share some information. Next week, we'll have another webinar, our last one for the year. It'll actually be on Wednesday at 4 p.m. Eastern. So if you're interested in learning more about the Whipple procedure, please register for that one. This individual just mentioning that their recommended bandage change from their doctor is once a week with 1 flush per day.
You may see some variation depending on how long the drain has been in place. I would say in most cases we do twice a day, but if you haven't had issues with clogging or leaking and you're doing well with 1 flush per day, I think, obviously that would be sufficient. In terms of the bandage change, I think, just as much as you're maintaining cleanliness and staying on top of all that, if once a week and you haven't had any infection issues, then I think that's okay.
This individual is asking if there's any connection between cholangitis and GGT numbers of blood.
You'll have to clarify what GGT numbers is for me.
While we wait for that person to clarify, what do you recommend for patients who have had a sphincterotomy to do to minimize problems with backflow of non-sterile gut material? Bacteria?
It's a good question, Emma. And if we had the golden answer to that one, we would have people with a lot less of the problems that they do. I think there's not a pill, and I don't think probiotics is something that helps, unfortunately, in this situation. It's normal gut flora, and you don't want to change that necessarily. The main thing is staying on top of if you have any signs of infection, and usually we can start oral antibiotics quickly so people don't have to be in the hospital, but I don't have a great recommendation to be able to prevent that.
This person says that they have leaking issues, so just twice a day help with leaking bile.
It certainly can. If there's some backflow, if you flush the tube twice a day, it may help with some of the leaking around the site. Yes. Not for definite, but it certainly can.
How should we be cleaning the exterior of the insertion site for the catheter?
Very good. So once you've taken off the actual dressing and you're looking at the abdomen where the stitches are attached, typically saline water is what is recommended. You can also use a small alcohol pad to clean in a circular motion around that site. But again, either one of those, as long as your hands are clean as you're doing that, you clean at the site with either alcohol or saline water, and then you redress it with a gauze bandage.
This individual's husband has major abdominal bloating since having a new plastic stent placed inside of his metal stent. Is it possibly due to bilirubin? Anything to do to reduce the bloating or the pain?
Sometimes people need further upsizing if possible. Sometimes you're at the max width of the stent, but it sounds like there may be compression that is causing, whether it's probably from a tumor on the outside of that bile duct, and doing as best you can to keep it patent, or talking with your provider about is upsizing possible. It may need the stent may need some adjusting to make it more comfortable and cause less bloating, because bloating is a side effect of stents not functioning well.
So going back to the question about cholangitis and GGT numbers, this person clarified GGT stands for gamma glutamyltransferase.
Yes, I don't know the answer to that one. I was wondering if that was what GGT was, but I don't know if there's a connection between those.
How or when does someone get into the situation of needing a stent? Is it expected to happen in the normal course if the tumor cannot be removed?
A lot of it depends on where the tumor is located. So some people have very peripheral tumors that are on the sides or the external parts of the liver. And so that's where the small little bile ducts are. And so tumors won't interrupt in those areas. And so some patients will never need a stent or a drain placed based on that. As we see in cases of tumor progression, and if they involve more areas where bile ducts are, it is pretty common that patients with cholangiocarcinoma will need them, but it's certainly not every patient that will.
Is the drainage information you covered applicable to an ascites as well?
So ascites, we use drains. One of the brand names is Plurex's. There's also Rocket catheters. There's a few different brands, but ascites doesn't involve the bile ducts per se. That is just a tunneled catheter that's in the abdomen. The signs and symptoms of infection are similar. You're monitoring it, but it's a very different, that's an individual hooks up a vacuumed drain to be able to get that fluid out. So not quite the same, but infection and all of that is something important to monitor, but it doesn't get blocked the same way that these do.
Once a plastic stent is inserted, can a tumor cause a stent to collapse or constrict?
It certainly can, and that's why people often, that's a big reason that they get occluded, because the tumors either grow into them or they cause collapse of them. So they need to either have a metal stent placed or they have to have the stent replaced. That is one of the biggest reasons, yes.
How often do you see patients that improve and no longer need drains or stents?
Being very optimistic, I think we do see patients with chemotherapy have significant improvement of this compression on the bile ducts, and so stents are able to be removed. There are patients who need stents initially, especially if the bilirubin is very high. We give chemotherapy and there's enough shrinkage and patients are able to go to surgery. So this is another surgery is a way that these stents can be removed when you're taking out the actual tumor, but typically initially they're in place. But yeah, I think we successfully see them removed, both from shrinkage from chemotherapy, or is it from radiation or surgery?
Talking of the bandages, does having a clear bandage, is that better or worse? The IR doctor uses one bandage and the liver doctor uses another type. So I guess what would you recommend perhaps?
I think it doesn't matter as long as you're monitoring it closely. I think if there is a liquid drainage, which is mostly what this is, a gauze bandage is going to absorb that better and keep some of the moisture off the skin. A clear bandage, yeah, you can see the site very well, which I think is, an advantage of having a clear one. The problem is it just holds the moisture in place, and so that's not good for your skin.
Is antibiotic ointment okay to put around where the drain tube exists outside the body wall?
I wouldn't do it prophylactically or just regularly, but if you start to see redness or some irritation, antibiotic ointment is okay. As long as you do your best not to put it right at the insertion site, but more around it.
Okay. Have you ever seen someone with a PTC tube have it removed after they have it?
Yeah, PTC is just a percutaneous drain. So yes, we do have patients have them removed. Sometimes whether chemotherapy shrinks some of the tumors that are causing the blockage that requires the drain to be placed or the tube to be placed. Sometimes they can be successfully internalized. So they have to have an external drain placed initially to really decompress the gallbladder because it was too tight to be able to go in from the inside. If you have some improvement or shrinkage of the tumor, you're able to have the external drain removed and they can put in an internal metal stent sometimes. So they can be, but I do caution that in many situations, they are a somewhat permanent fixture. So we do our best, and I think you need to advocate and ask the question regularly, can this be changed to something, can we internalize this, or can this stent be removed? I think, again, continuing to advocate for that, because having these on the outside is very disruptive to life, whether it's just a cap drain or whether it's one that's open to a bag. Again, you can't swim and things like that many people enjoy. So yes, they can be removed. Yes, they can be internalized is another word, but not always.
Do you feel like metal or plastic stents are better, one or the other? It just depends.
It completely depends on the scenario. So metal stents are typically sturdier and they can be more permanent, but they are not the perfect solution either. And if they know it's a situation where multiple upsizes are going to be needed, it's this very small opening, they can get a small one in. They know in a week or two they're going to have to increase it. You're not going to do a metal stent from the start. You're going to have to take the time with the plastic stents. And if it's something that they're hoping is not going to be permanent, meaning it's a temporary thing, a plastic stent is pertinent in that situation.
Okay. Are metal stents permanent?
They can be, yes. They don't have to be, but the metal stents, if it's pretty clear that there is going to be a stent, there's going to need to be a stent in there for the foreseeable future months, then often a metal stent will be placed.
Okay. And then how long have you seen plastic stents work for? Do you feel like they need to be changed more frequently? And if there's a certain interval to those changes?
So many of my patients have only plastic stents. And so they do have a role, and they can need to be changed more frequently. Usually it's 8 to 12 weeks, every 8 to 12 weeks, if not sooner, if there's difficulty. But I don't think, even amongst my patients, I think there's more of a negative thought against plastic stents, and it's more just they serve different purposes and different permanence. sometimes. And so it's not that plastic stents are negative. They can be a little bit easier to use. And so they certainly have a role, and they function well to do that role.
Okay, well, that's good to know. This individual is just sharing that they started using Mepilex silicone foam dressing, which is much easier to compared to the gauze, and it helps to keep the drain dry in the shower without the saran wrap. So that's good to
Yes,
know.
the Mepilexes are very nice and they're water resistant. They just aren't inexpensive,
Okay.
but they are a nice dressing.
How does one go about having one IR person do all of the procedures for continuity of care?
I wish I could say at our institution that was a consistent thing either. It depends. Many of these procedures are not planned, meaning you have your first one placed on whether you came through the ER or it was, on initial diagnosis, and you have one IR doctor do them. Say on a random Saturday, you have an infection and you have to go back to the ER. There's no way to be able to have the same one. What we try to do is preempt them. So if we know somebody has a drain, usually in the IR note or the endoscopist note, you'll see change in X amount of time. Everyone has access to their records, and so you can see the recommendation. And I do my best to work with patients and have them stay on top of this and and we pre-schedule the next one with the provider who did their prior procedure. So that's one recommendation, to try to be proactive about it, but unfortunately, they often dictate their own course. And people go to different locations. I mean, also going to the same hospital repeatedly helps, but sometimes you cannot help where you are when something happens. Or if you have to call an ambulance, for example, they take you to the nearest place.
Yeah. In terms of that, we also have the biliary stent card that people can use and write down information. So that's definitely a good way to, just in case maybe you're traveling or something like that, that could be accessed as well. This person is asking how they should better advocate to have for their plastic stent to be replaced by a metal stent.
So that's an important conversation to have with the proceduralist. The medical oncologists aren't necessarily even the best person to ask in this scenario, because the nuances that the proceduralists know is important. So when I send my patients to IR for these procedures, they often don't have an appointment with that provider. It's just set up for the procedure and they go in. But you can ask to have a video or a phone conversation or even an in-person conversation with the GI doctor or the interventional radiologist to have that conversation and see what their reasons are for why or why not, and specifically to your case.
Are stents different lengths? And if so, what criteria determines the length?
Stents are different lengths, as one can imagine. So cholangiocarcinoma can be a round tumor that goes around a bile duct, but some cholangios are very interesting, where it's especially the ones that are internal and cause the compression from the inside. They can just travel up the track of the duct. And so those ones need a much longer stent, because if you have tumor covering a few centimeters, you're not going to put one halfway through, because you'll end up with the same problem. So those folks need a large one. But if you have a small tumor, but one that's really constricting the duct, you may only need a short stent there. So they determine that once they're in the procedure.
This person ended up with an abscess in the liver. Does having a stent make this more likely? Oh, so like, did it cause maybe having that abscess?
There are so many reasons that people get abscesses, unfortunately. One of those reasons being when you have a stent placed and they do the sphincterotomy and there's ability for bacteria to backflow into the liver. This bacteria can pool and form an abscess. So my patients without stents have abscesses for multiple reasons, but I would say that those who do have any hardware and any manipulation within their bile duct, whether it's just they go in and don't even have a stent placed, but have some form of procedure, are going to be at an increased risk for that abscess. Unfortunately, though some of that is unavoidable, to be able to place these, which are necessary.
I don't see any other questions, but if anyone has any other questions, please enter them in. These are all great. Is there any reason why a doctor would choose not to if they have one stent on like the right side, they would choose not to do it on the left if there's also like blockage there? That's probably a little bit more of a personalized question, but
Sure. So, the point being is you want to have as minimal, as few drains as possible to try to achieve drainage of the bile ducts. And in every instance, doing both sides may not achieve that. So if it's realized that it may not be able to be achieved, you're not going to add an extra one if you don't think it is going to help, if there's too much blockage.
how can you tell if it's an infection versus chemotherapy reaction?
Well, this is why I'm employed, because it's very challenging to know, to piece those things apart. And some of it is timeline. So we know that the chemotherapy and what adds to all of this is that we are immunosuppressing patients with chemotherapy, decreasing white blood cell counts, and making people much more at risk for infection. We treat it all the same. Chemotherapy reactions typically aren't going to, sometimes gemcitabine, which many people are on, can cause low-grade fevers, but they're not typically very symptomatic. So not having rigors, not having high fevers, but we would work them up the same, and we would want patients to call just the same. So let us differentiate that and not you guys. I think that's where sometimes people get into trouble. They're like, oh, they said this could be a side effect from chemo, so I think it's that, and I'll hang tight. But then people can get in a lot of trouble making those decisions themselves.
So when in doubt, go
Call.
to see your yeah.
Yes.
Do you often see stents and drains placed due to a bile duct leak post
Hepatectomy. So after you've had a liver surgery, yep. So it's a completely different reason. So I was talking specifically about people who have their primary tumors in place and or have blockages from tumors. People who have bile duct leaks after a surgery need drains, but it's to allow healing. It's not to open a blockage, if you will. So they are present, but it's for a different reason.
Great. Well, thank you so much. This has been very informative. I hope that everyone will use your information as a great resource. And we will have this posted on the YouTube channel after probably by tomorrow at some point. So if anyone wants to reference back to it, it is available there. And Paige, thank you again.
You're welcome. Take care.
Thank you. You too. Bye, everyone.